And thank you for the Canon team. Welcome. So this looks like a stage, right? So I come from the UK, and this is like the first part of a Shakespearean play. So this is very much a preamble to the rest of the day. So today what I'm going to talk about is AI. So the first person that I'm going to bring is someone that used to live in Cambridge, but came here, made his home in Toronto for the last 20 years or so, and became the godfather of artificial intelligence. And one thing he did was, as he worked through last year, May, he basically sent ripples through the AI world by resigning from Google, citing the risks of AI. But at the same time, when he left with this parting word that our brains have 100 trillion connections, and ChatGPT has about 100 times less, but they're more powerful. So could AI be smarter than us? And the second thing is related to us helping patients, right? So, in terms of empathy of the physicians and how we work together, there was a study by JAMA last year that basically said that looking at physicians and the way they collaborate and checking lots of different responses by both physicians as well as ChatGPT, the panel of healthcare professionals who looked at those responses found independently that the ChatGPT responses were, both in terms of quality, perhaps about, 3 times more better, and in terms of empathy, about 10 times better, right? So, the question is it right for us with AI? Has it come of age, right? So today I'm going to talk about a few more background in terms of AI, look at collaborative imaging as the essence of AI within Canon, talk about lots of clinical benefits of our solutions, and then end with a story of how we're implementing this in clinical practice without changing the workflow. So within the industry, we work a lot with RSNA, with different societies. Pre-COVID, between 2016 and 2018, we were sent this challenge by Professor Lancelot, who is the next president of RSNA, and his team, to say, the first thing that you need to do is to optimize the acquisition using AI as the principle of gathering data, right? So garbage in is garbage out, and gold dust in is gold dust out, right? So in that context, we have been working with them for quite a long period of time, and you'll see later on that in 2018, we implemented the first AI-based solution on the device itself. Secondly, lots of different institutions and also European Society of Radiology, for example, are talking about personalization of patient care, patient protocols, etc., where training and robust training of data is the most important thing that you need to undertake in terms of getting to the nirvana of N=1, i.e. patient-centered care. And then there are governments that have taken up lots of decisions, and there are industry bodies that are now rolling out a plethora of solutions. And most of the solutions are based on diagnosis and treatment at the point of care delivery in terms of post-processing. That's where most of the devices that are regulated by Health Canada and FDA sits today. And finally, the government itself have lots of rule books and guidance, right? So this is the National AI Strategy within the UK that was implemented a couple of years ago. And as a result of that, all the RFPs that are there within the UK now has elements of AI embedded into it. And in May this year, the Prime Minister here also came up with this incentive in terms of investing 2.4 billion Canadian dollars to secure Canada's AI advantage in terms of budget for 24 onwards, right? So I'm hoping that we will get some of that budget within Canon in terms of improving patient lives as well, right? So having said all of that, in terms of looking at the care process that takes place, data is everything, as we talked about earlier. So changing the data into information and then turning that into insights for patient care is the most important thing that we strive by in terms of what Ian said, which is made for life philosophy within Canon. So in terms of potential to apply data, right, there's the potential to apply it at acquisition in terms of looking at cameras within the scanner itself, looking at landmark detections, etc. And secondly, to consolidate all of that data and then to use that through deep learning, machine learning, etc., to then come up with insights and reports that is used as part of a routine workflow. The thing that we're all looking for is value from AI-driven solutions. And in terms of value from AI-driven solutions, the first thing that you look at is from an acquisition, how do you acquire images that are of very high quality, less noise, and faster, right? So the 3 dimensions of acquisition that we want to optimize with AI. And then that is then delivered over to you as clinicians. And what we want to do with AI is to ensure that there's A, repeatability, B, accuracy, and C, we want to make sure that the routine tasks are done by AI so that you can be more of a specialist and a subspecialist in terms of what you do without needing to look at extremities all the time, for example, right? All of that can be taken care of by AI. And then as a result of that, we want to ensure that we have improved patient outcome. So within Canon, we put patients and yourself as partners right at the center of our ecosystem, and we have AI from an end-to-end workflow, from acquisition all the way down to intelligent algorithms delivering the insights so that you can make the right decisions for the patients. And many of our speakers will talk about solutions such as the Altivity solution that we have, which is our brand that allows us to ensure that we do rigorous testing against the very basis of deep learning that we need to pass before we have the Power by Altivity logo in the slides that you'll see for the rest of the day. And in terms of going out to market, Professor Lancelot's challenge, when he released the paper in 2018, just before RSNA, at 2018 RSNA, we're the first company to basically come out with the first deep learning reconstruction scanner. And that has now gone into lots of generations and iterations. And you hear speakers talk about PEAK, which is used for both CT as well as for MR and other disciplines as well. So this is ultra high resolution data that is used to train the images and then give that output as trained images to all sorts of scanners and to different body parts as well, right? So this is one example of MR-based solutions using PEAK, where we use high resolution as the input data, and then we ensure that the conventional data is then utilized with PEAK so that there's very high resolution of the output with very high signal-to-noise ratio, and more importantly, we decrease the scan time in terms of the lumbar spine acquisition that you've seen. Similarly, we use deep learning for other modalities as well, right? So today we're not represented by the vascular modality, but within the vascular solution, we use deep learning to ensure that we use all of that data with real-time noise reduction. And then on top of that, we apply a lot of filters with regard to multi-frequency processing to ensure there are 2 things that are delivered. One is double contrast to noise ratio with regard to images, so you can compare the fluoroscopy images with the output images of alpha evolve, and also reduction of dose, which are 2 criteria that we need to look at in terms of vascular. As a result of that, what you see here, when you compare the cine acquisition with the fluor acquisition on the right-hand side, is substantial reduction of dose, improvement of quality of the images. You can see the stents very carefully, and you can see the graphs very carefully as well. Within this institution in Switzerland, they have now stopped most of the time doing cine and instead doing fluoro as part of the routine examination because of the value of AI that we have. And similarly, we've got solutions related to ultrasound. In ultrasound, we've got a number of different solutions, but we integrate all of that so that we can have multi-fusion of CT data with ultrasound data, CT PET data with ultrasound data, and ensure that we have the targeted locations done so that you can do planning of patient acquisition in a very robust manner. So that is scanning. In terms of pre-scanning with regard to protocoling, as well as for results generation with regard to post-processing, we've also got a lot of AI solutions driven by the Instincts platform. And Instincts is something that Dr. Bull and others will talk about quite a bit. Right, so Vitrea is part of the Instincts platform. We deliver Vitrea as part of our post-processing solution. And one of the things that we've done over the last few years is to ensure a lot of automation and AI is part of the Vitria solution itself. So these are some snippets, right? So we all know that, in terms of all the trauma cases, about 10 to 25% of trauma cases will result in, for example, one rib fracture, right? And about 30% of all the all the chest scans will have some sort of a rib fracture in emergency. So what we do here is we have we sort of like change the paradigm of looking at CT images, which normally takes a very long period of time and is a tedious process, by providing a one-scan view called an open rib view, as you can see here, with photorealistic rendering images on the right-hand side, so that it's very easy for you to locate where the fractures are. So this is done with zero-click automation. And similarly with regard to taking acquisitions from scanners, ensuring that we tilt the scanners in the right way so that we've got automatic windowing, and this is then sent over to the PACS system automatically. This saves a lot of time for both the radiologists as well as the clinicians, right? And then we also have applications that are within the scanner. So for example, subtraction viewer has been within our scanner for quite a number of years. And the problem with that was you could only use with acquisition data in the scanner itself. What we have done is we have now ported this over to Vitria. So across the enterprise, in a very automated zero-click environment, you can use subtraction viewer, extract out information, and fuse the images together as part of your routine workflow. We also have solutions that look at, for example, in this particular case, we have been working with INCO in Brazil, which is a very big site for cardiology. We had written papers many a times that shows the perivascular fat around the artery and the correlation of that in terms of prediction of future disease states. So that is what we have capitalized here. And then with the perivascular CT density solution, we can look at the lumen, we can look at the outer wall, and then predict what's going to happen with the patient in terms of analysis and detection. So those are some examples. And then we then deliver this through various modes. And one of the modes of delivery is AI-based platform called the automation platform. This is a platform in its own right. We want to ensure that we integrate a lot of different solutions into this particular platform, right? So that we don't get you to look at 10 or 12 different results. We want you to look at one consolidated results from all the different applications that there is, so that we change the paradigm flow of conventional workflow, which takes many steps, as you know, as clinicians, to get to the care team. But instead of that, what we do is we have a centralized server that listens to the data that's coming in, and then passes that data and sends to the right AI algorithm that sits at the back. And the AI algorithms are then prioritized and sent to the care team, right? And you'll see that example later on today, right at the end. So within this automation platform, we then house the AI solutions as well as the non-AI solutions, because we don't want to miss out the fact that there's a lot of value with regard to the traditional non-AI solutions as well. And what we do into that is powered by Altivity. We have a lot of different applications. So here, for example, we've got the CT stroke applications, including ICH, LVO, the Bayesian CTP algorithm, which is unique to Canon, and of course, something that is quite local, developed in Alberta, the aspect scoring. And then on top of that, we also put the stroke MR solution so that we can then look at onset time, et cetera. And then we can build up different solutions, right? So for emergency, for example, we've got solutions that look at reducing the time for pulmonary embolism, ensuring that there is a lot of efficiency in terms of getting out to the PE. For critical cases like aortic dissections, we also analyze that straight off. And then having chest X-rays and chest CTs, we want to ensure that from the chest CT itself, we also have incidental PE that is delivered. So all of this is delivered, as I said, in an integrated fashion using one single report called the Insight Results, right? So this is a concise result that is then shared out to the team. And you can see from the results, you have the summary of what the result is all about, including the aspect ratio, no suspected hemorrhage, and the quantification of that. This is then sent out to the entire care team, right, with zero click across the board, right? So with all of this in the back, the final 5 minutes of my presentation is about a delivery of this solution within one of the sites very close to here in Buffalo, New York, right? So in this particular site, our mantra was, how do we save time for the patients so that the time to brain analogy that we have is optimized. And of course, within the institution, we wanted to ensure that the JCI criteria of door to needle time was minimized as much as possible. So Gates Vascular Institution is quite a unique site. It is a tertiary care site. There are lots of referring sites from other institutions. So from other institutions, as you send the patients over to this particular site, the images are taken up automatically from the other side, and the results are sent to the tertiary site, so that as the patients get sent from the secondary site to the tertiary site, there's prep for that particular patient, right? And we all want to ensure that the patient is treated in as quick a manner as possible. So we did a lot of analysis in terms of what are the different aspects of triage for ischemic stroke patients that we can use AI to enhance care and reduce and minimize the delays. And we found that in terms of door to needle time, there are a lot of different criteria right at the middle there that you've seen in red that we can optimize in terms of ensuring that we reduce the time, right? So within this institution, we put our solution in with our scanners, as well as with the automation platform solution and the Vitreous solution, integrated that without changing the workflow substantially within this institution. We're very lucky that we've got a one-stop shop that allows us to do both CT as well as intervention in the same room, with fluoro on the side and ultrasound on the side as well, right? And this is our 10th hospital in the US with this sort of setting, but the first hospital with 4D CT scanner within the emergency department. So we've really looked at how this can help in terms of the target, which is hard to do, which is to get from door to recanalization within about 30 minutes. So within this particular site, with the CT scanner that we have, which does a one whole brain workup within 60 seconds, including the different phases that you see, plus the CT perfusion data and the dynamic CTA, we send that data across. As you saw earlier, for both contrast and non-contrast, we've got solutions that look at this and then deliver this for care. So in terms of delivering this for care, if you look at the timing, the most important thing here is to reduce the time for the patient when you go from one part of the workflow to the other. So as a patient arrives from ED, the transfer of patient from ED over to triage room, from the triage room over to the CT room, from the CT room back to the triage room, from the triage room over to the intervention room, all of that takes time. Average 15, 20, 25 minutes, right? So with this particular novel integration of the solution within one single room, we put patient at the center of care. The patient, once you are triaged, gets on the CT scan, right? And we ensure that the rest of the workflow works around the patient. So the scan gets taken. As soon as the scan is taken, the results are sent out directly whilst the patient is there to make an informed decision automatically with zero-click workflow, ensuring that there is quick access to the results itself. Once that is done, then you engage the team, right? So you don't send the patient over to the waiting room, and you don't send the patient over to the intervention room, which is separately. You make sure that that's done within one single institution itself. Then once that is done, you ensure that the team moves around the patient, right? So so this is really patient-centric care, right? And so we want to ensure that the scheduling of the doctors are not there in terms of conflict, because you need to ensure you move the doctors from that room and to the room without moving the patient from one room to another, right? So this increases the likelihood of outcomes, which are very favorable. And the most important thing is we have improved the performance matrix here substantially in terms of solution delivery. So within the last 20 minutes, what we have done is we've talked about the Canon solution in terms of end-to-end care, right? So with intelligent devices all the way down to decision support, right? So with intelligent devices, we've got a lot of solutions that provide optimal image quality. This gets delivered over to the AI engine that does the categorization, sends it over to the algorithms that delivers the information using insights, and then that is used to augment the care decision process. So in reality, we take the human and clinical-driven innovation, integrated with AI, and ensure that we try to get to the nirvana of n equals 1 in terms of patient care. Thank you.